Welcome to the Spark Live webinar series, one component of our Spark Knowledge Mobilization Program. Spark is Children's Healthcare Canada's shared platform for advocacy, research, and knowledge. Spark Live is where we gather each week to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community. Our goal is to spark conversation, ideas, and action. Children's Healthcare Canada would like to thank our funding partners for their ongoing contributions that support all of our programs and activities, including this Spark Live bi-weekly webinar series. There are two options to join in on the live conversation. Questions and comments for our panel or presenters can be typed into the question box, or comments that you want to share with the audience can be typed into the chat box visible to all of our attendees. For those of you on Twitter, tag @ChildHealthCan on any webinar-related tweets or use the hashtag SparkLive. And to keep up to date on all of Children's Healthcare Canada's webinars and other activities, be sure to sign up for our weekly Spark News e-bulletin by visiting our website at childhealthcan.ca. Hello, and welcome to another edition of Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Before we begin, I want to acknowledge that Children's Healthcare Canada's offices, located in Ottawa, are on the unceded, unsurrendered territory of the Algonquin and Anishinaabe people. We recognize and deeply appreciate the historic connection to this place. We also recognize the contributions that Métis, Inuit, and other Indigenous peoples have made in shaping and strengthening this country, our province, and this community. This month, our Spark theme is child and youth mental health. While the mental health and well-being of Canada's children are always a priority, COVID-19 has really shed light on the increase in struggles for children and youth in our country. This inequity in children's mental health services. With that, today we are proud to bring you Informing Equitable Child and Youth Mental Health, Tailoring to Support Diverse Groups, featuring Dr. Bukola Salami, Dr. Tricia Williams, and Dr. Jennifer Zwicker. We will be covering the topic of equitable mental health care from three different lenses today. We will hear from our experts on mental health of Black youth, mental health supports for neurodiverse children and families, and policy design inclusive of those with a disability. Before we begin, we invite you to answer a few quick poll questions for us. Please note that you'll have to answer all three questions before you submit a response. And while you're answering those poll questions, I want to thank you for participating. During the presentations, we'll welcome you to the conversation in the chat box and type your questions in the question and answer box. Please indicate for whom the questions are directed, and we will pose them at the end of the webinar during the roundtable Q&A with our panelists. Now, I would like to introduce you to our first speaker of the day. Dr. Bukola Salami is the Director of Intersections of Gender Signature Area at the Office of the Vice President Research and is an Associate Professor at the Faculty of Nursing, University of Alberta. Her research focuses on immigrant well-being and Black people's health. She has been involved in over 75 funded studies in this area, and she's also the Associate Editor of the Canadian Mental Association Journal, an advisory board member of the CIHR Institute for Human Development, Child and Youth, and has received several prestigious awards for her research excellence and community engagement. It's now my pleasure to pass the mic to Dr. Salami.
I'll be presenting today on mental health of Black youth, and apologies for that. So I'll be presenting a study I completed, two studies. One that I completed in February 2020 about the mental health of Black youths. In another study that we just started, we've done interviews of around 30 Black youths. We just started over the last 1 month on how the pandemic affected Black youths. For the second study, we're still very early in the stages of interviews, and we've not fully analyzed our data yet, but I'll just share a few points that have been raised. So for the first study, we interviewed 30 Black youths, and we conducted conversation cafes, which is group conversations with 99 Black youths in the province of Alberta. Some of the factors that youths talked about influencing their mental health include racism and discrimination. So the first Black youth said, I grew up with so much internalized racism. God, I hated myself. I wanted to be white so bad. I wanted to have straight hair. That same youth talked about being someone throwing a Slurpee at her as she was crossing the street and calling her the N word. Also, the influence of race, gender, and masculinity. So one you talked about in the Black community, people understand. But when he goes outside, he always has to prove himself innocent because people always assume that he's guilty. So imagine if you're a Black youth and you're guilty until proven innocent. Another you talked about toxic masculinity, and the whole perception or general thought that toxic masculinity is a Black thing. And he challenged that notion and said, this is one of the things that is impacting on his mental health. Cultural expectations was discussed, or the notion that, people often view that mental health is a Caucasian problem, and that mental health of Black youth is often not addressed. Academic expectation was often talked about with our youths and the stress related to juggling academics and achieving career success. Openness about about mental health was a positive factor that influenced mental health of youths, and also a sense of community also influenced the mental health of youths. Youths generally talked about the influence of spirituality, so they would say that if they experience mental challenges, that they pray, that they sing, and this was a positive impact on their mental health. And access to health services was hindered by cost of mental health services, by geographical barriers and distance. And many of the youth said many of the mental health services often tend to be located in areas that are mainly for that they consider white spaces, or in neighborhoods where there are more white people than Black people. And also lack of demographic representation. So one Black youth said, there's never any Black counselors. That's the biggest problem. Now, how am I going to tell a white person that there's no food in the fridge and you're stressed, you're crumbling, and you can't do your own work, and your teacher thinks you're a lazy person, and you're not going anywhere in life because all you do is play basketball because that's your outlet. Now, this has an influence too, post-COVID-19, as I will discuss later, because a lot of Black youths, they engage in sports as an outlet to address mental health issues. But COVID-19, as I will show in a future slide, affected the ability of Black youths to be able to participate in sports activities and in turn, their mental health. Another youth talked about going to a mental health counselor and saying, oh, I'm experiencing racism and it's impacting my mental health. And the mental health counselor, just because they're not skilled at dealing with that, they try to brush over it and move to something else. And also lack of knowledge on mental health services was discussed by the youths. Some of the barriers to mental health services identified by youth included intergenerational gaps. So especially Black youth from refugee backgrounds, their parents may already be struggling with their mental health concern. And due to the inability of parents to adequately address their own mental health, it may impact on their ability to support their youth in addressing mental health concern. Stigma and judgmentalism, which is not just within Black youths, but across all societies related to mental health. And also in Canada, youths talked about the culture of independence in Canada and how the culture of independence in Canada affects their mental health. Youths also talked about the influence of peer support, which is positive influence on mental health. And of course, the other thing is, this had an influence, the youths we interviewed after the pandemic, because the peer support we are often lacking. And that was really a core strategy that supported youth's mental health. Use of religious teaching and practices, music, and in a negative way, self-imposed isolation. So I should say this project, we did the initial picture that I showed. It was a participatory research where the youths shown here were actually the youths that collected the data. And they presented this data several times. They were advisory committee member, research assistants, and this was a participatory strategy with youths. Our currently funded CIHR project is looking at mental health of Black youth post-COVID-19, or how COVID-19 has affected the mental health of Black youth. And we're interviewing around 30 Black youths. We've interviewed around 28, but just in the early phases of transcription has been slow. And we are also doing a survey of around 800 Black youths across Canada, which we have not started yet. Some of the factors that youths talked about impacting their mental health post-COVID include income, food security, and mental health. So losing their jobs, not having enough food, and mental health. Barriers in terms of sports participation, isolation, navigating the immigration process. So the immigration process is more prolonged for immigrants, youths, or international students who are youths, and that creates a challenge. Resilience. Many of the youths, even though they experience several challenges, they always often talk about someone else had it worse. So they know someone else that had it worse than them. And they often, talk about their resilience throughout the process. They also, at the same time, are juggling academic pressure. And, there's been more challenge with academic pressure, given the fact that, less support in terms of, and also distance learning and the challenges that presents. And anxiety about the vaccine was discussed. And also Black youths were not just experiencing the pandemic, COVID-19, but they were also experiencing the effects of Black Lives Matter movement and the trauma that it caused at the same time. And this was a challenge for youths. So I'll just present two quotes. And one quote was about immigration, isolation, and mental health. And this person says, so I was lucky in that sense. However, it's been hard. I would say, like romantically speaking, like it's been lonely. I would have felt this lonely if that wasn't COVID. You know what I mean? Like dealing with immigration alone is one thing, but like for COVID on top of that, like it's affected my ability to meet new people. So I think it's affected that in terms of my familial relationship. It affected that in terms of immigration side because immigration has been slow. I can't leave Canada until I get my papers. And so I've not seen my mother and my sister in a long time. Income and mental health was also discussed. So this youth discussed how anytime there's a spike in terms of COVID cases, he always gets really, really anxious because he knows that the employer is going to cut his hours. And he knows what the effect of that means on his income. So, it's not just the physical impact of COVID, but also just the announcement that there is a spike leads to challenges with mental health. The time is short, so those are the only two quotes I can provide, but I can talk more after, and sorry about that.
Thank you, Dr. Salami, for an important presentation on the mental health of Black youth. Before we move on to our next speaker, I'd just like to remind you to please put your questions for our speakers in the chat or the question and answer box and indicate who the question is for, and we'll pose them at the end of the session. I'd now like to introduce Dr. Tricia Williams. Dr. Williams is a board-certified clinical neuropsychologist and pediatric subspecialist through the American Board of Professional Psychology. She is a clinical neuropsychologist and health clinician scientist at Sick Kids in the Division of Neurology. In her clinical role, she leads the neonatal neuropsychology services for assessment and consultation for children and families following neonatal brain injury and associated medical conditions. She is the director of the Sick Kids Neuro Outcomes Lab and a co-chair of the Family Advisory Committee. Dr. Williams, over to you.
Good morning, and thank you so much for inviting me to be a part of this really important panel for discussion. Today, I'm going to be sharing with you the story of iInteract North, a parenting program that was developed with and for parents of children who'd experienced early brain injury or conditions that impact neurodiversity. I want to express my gratitude to the many parents that have been on this journey with us, and I sincerely hope that I do our story justice. So as Paula shared, I've been a clinical neuropsychologist at Sick Kids for almost 10 years, and I work with children and families following different kinds of neonatal brain injury and conditions that impact brain development. The role in follow-up for these children often emphasizes assessment. So follow-up at 12, 18, and 36 months. And then they transition to my clinic where I help with the school transition and then at other key developmental times throughout their childhood and adolescence. We know that there's been dramatic improvements in the medical outcome of these children. The improvements, though, in mental health outcomes have not had the same success. And this was echoed in our early work on parent priorities, calling for us to see this as more than a medical condition. Parents discuss often the invisibility of disability associated with brain injury, particularly when it happens at such young ages. We also saw children who had mental health difficulties, particularly early emotional and behavioral concerns in the early years. These children were at an increased risk for negative long-term outcomes. And what we heard from our parents was that less than 10% of the samples that we had in our research studies had access to any mental health supports for their children during this time. So this led to our first co-design project, the Parent Experience Study, where we sat down with parents from our neonatal follow-up programs and created a new measure that would prioritize the outcomes that mattered most to parents. And this largely focused on mental health of the children, but also, importantly, of the parents. Parents reflected how difficult it can be to ask for help for them as a parent. Often our focus clinically is on the child. From these surveys, we learned the parents prioritize their child's social and emotional well-being, and really were looking for support on how to improve their own skills and confidence in these domains. Our parents were also asking for more support in helping navigate and understand the complexity of early brain injury. Now, this study was done over 3 or 4 years ago, but they list many of the common barriers that exist today in terms of, the time off work, accessing services, at established community-based centers, and the associated difficulties in managing this in busy lives. But I want to highlight one that was unique to this group, which was the lack of fit in many well-meaning and evidence-based parenting programs in the community, given the lack of information or support or knowledge of what it's like to raise a child following brain injury, not just in understanding the neuropsychological outcomes, but also the impact on the parent and on the family system. And this all led and culminated in the iInteract North program I'll be talking about today. Dr. Sherry Wade at Cincinnati Children's developed iInteract Express following older children with traumatic brain injury in the late 90s. The reason we chose her program to pilot among our cohorts was really 2 main reasons. One, the program had been delivered virtually and had success in improving the concerns that mattered most to parents, the challenges around behavior and emotion concerns in these early years. Another reason we selected Dr. Wade's original program was because it embedded psychoeducation around raising a child with brain injury. We completed the initial trial of this virtual program prior to the pandemic. We established, almost uniform acceptability, parents' pleasure of reaching this in their home, and the flexibility our program could offer around evenings and weekend scheduling. We also showed that the program worked in terms of parents' reported improvement in the child's behavior and family stress. Using the feedback from that trial and then engaging a new group of parent stakeholders, as well as members of our community and our clinical pathways, we built the iInteract platform that you see here today. We called it iInteract North to reflect the Canadian context, but also to the focus that and feedback from our congenital and neonatal type conditions that we were hoping to reach. So the major changes that you'll see in this website, in this program, are that it's transdiagnostic, and it highlights parents' experience across these different conditions. So you'll see some beautiful testimonials on what it's like to raise a child following these uncertain conditions, but also how the program has been integrated in the family's life. We also made it more user-friendly, so it could be accessed across multiple devices. So very briefly, iInteract North, and it's how we built it, was 7 sessions. There's learning modules the parents can now complete at any time on any device. And each session is coupled with a one-on-one coaching session. And the coaching sessions have multiple purposes: to reinforce what the parent may have learned in the module, but also critically to adapt it to that family's special situation. And following positive parenting principles, learning how to build consistency and break down cycles of negativity that can happen often when you're raising a child with maybe difficult to control emotions or behaviors. The coaching also provides reinforcement to the family, so direct coaching of parent-child interactions in their home. And if anyone's interested, the website's shown here. Now, given our program was already virtual, our transition to COVID-19 was relatively seamless, and we extended our reach across the hospital to sick children for families in need. Families reflected how important and how amazing it actually was, that how these simple activities in their daily lives could change relationship with kids during this time, during COVID. And as you can show here, our efficacy results were also actually stronger than our pre-pandemic in decreases in intensity of problems reported in the home, as shown in red, and the number of problems, as shown in blue. However, like many programs during this time, there were additional barriers for families to participate. So despite need, parents often got to session 3 and 4 and were very burnt out with the multiple demands on parents. Many of us were spending entire days, as were our children, online. So this led to our next adaptation of the program with that feedback. We followed and broke our original 7-session program into 3 steps. We added a podcast based on one of our family advisory members' suggestions. She reflected how tired she is of getting handouts or just directed to another sort of static website. So we made an interactive podcast that gives some parents self-compassion and reflection and simple strategies to use in the home from parents and experts' perspective. Then, based on need, parents are graduated to an abbreviated positive parenting, given introduction and some brief coaching on how to use positive parenting and build some consistency in the home. And finally, at the end of session 2, families have a collaborative discussion with their coach, discuss where they are, the progress they've made, their continuing concerns, to make a decision on whether or not the full program and additional 5 sessions works for their family's needs and the reality of their availability. I'm really proud to share that we partnered and we were able to extend this beyond sick kids in partnering with the province of Ontario's neurodevelopmental network to reach families of children with ADHD as well as autism, who we knew were at heightened risk for mental health decline due to the pandemic. We are currently analyzing the results of our STEP Care program, but we have preliminary evidence to support its feasibility and acceptability. Parents reflected on how therapists can adapt the program to their child's special situation, as well as the empowerment they have in the decision-making process. And finally, as shown here in preliminary estimates of efficacy, you can see that even after the abbreviated approach, there are gains in positive parenting skills observed in these sessions. So in conclusion, I hope our story reflects on some solutions to reach families in need who historically had barriers to accessing these treatments. And I hope you've heard throughout my presentation how parents' priorities and voices have been critical at every stage in the implementation of this program, from planning, from the adaptations, and now as we move forward into answering the question how a program like iInteract North could be sensitively and safely embedded into clinical care pathways, so that we may begin to consider how we can not only assess these issues, but also start to address them in the early years. Thank you.
Thank you, Dr. Williams, for that great presentation. For our third and final presentation, we have Dr. Jennifer Zwicker. Dr. Zwicker is the Director of Health Policy at the School of Public Policy and Associate Professor and Canada Research Chair in Disability Policy for Children and Youth at the University of Calgary. She's also Deputy Scientific Officer for Kids Brain Health Network. Her research assesses interventions and informs policy around allocation of funding, services, and supports for youth with disability and their families. Her work recently informed the Canadian Academy of Health Sciences National Autism Strategy Working Group and the Royal Society of Canada Expert Working Group to develop disability inclusive policy during the pandemic. She has been recognized for her policy leadership in various ways, including being named one of Canada's top 40 under 40. It's my pleasure to pass it over to you, Dr. Zwicker.
Thank you for that introduction. Can you see my slides okay?
We can. Looks
okay, great. Perfect. And thank you for the invitation to be here. And thank you to the other panelists for their really fantastic and really insightful, important presentations. I just wanted to acknowledge the traditional territories of the people of Treaty 7 region in southern Alberta, and I'm coming to you from the city of Calgary, which is home to the Métis Nation, Alberta Region 3. Today, I'm going to talk to you just a little bit about disability inclusive policy for children with neurodevelopmental disabilities and their families. And in some ways, it builds really well on Dr. Williams' presentation that you just saw. The key messages I want to talk about are first, and especially because we're thinking about this in the context of mental health. And, I just wanted to make that link between the importance of policy and programs and services and supports for families and the impact on mental health. So one of the things, we've been seeing in particular during the pandemic is the disruptions, the delays, and the denials in access to services to disability supports and services. And that has a really profound impact on mental health. And we're seeing that in real time right now with the pandemic, and we were seeing it before the pandemic. Disability inclusive policy responses are critical to mitigate mental health impacts. And I'll talk to you a little bit about what that means. But the key point I'm trying to make is that, this can't just be one program or one service. It needs to be an approach, across ministries, both federally and provincially. So this is a map that one family has drawn, just depicting some of the supports and services that they are accessing and navigating in their daily lives in support of their child with developmental disability like autism or cerebral palsy. And the access to services, as you can see here, it's fragmented. There's many of them. It's navigating different eligibility criteria across ministries and programs. It's spanning school and health system and community and social services and advocacy and leadership kind of groups and recreation supports in the community. So, it's a lot to navigate. And I think, so we've done some work that I'd love to talk to you about some other point around evaluating care coordination and evaluating importance of kind of trying to harmonize some of the eligibility and access to these programs, because the real key here is that this is challenging to navigate, and it's a lot for families to navigate, and it has impacts on quality of life and mental health already. In the context of the pandemic, we've added this extra layer, and I'm going to talk a little bit about a study that we're in the middle of right now, looking at experiences of youth with neurodevelopmental disabilities during the pandemic. So and this is in partnership with Dr. Keiko Shihako-Thomas at McGill, where we've done a policy scan for disability inclusive policies. So we were kind of asking the question, when policies were rolled out in emergency responsiveness to the pandemic, what disability inclusive aspects were there? Were there kind of accommodations for youth with disabilities and their families? We've also done interviews with caregivers and youth across the country, 40 youth interviews and 40 caregiver interviews to understand or describe experiences, and have been looking at doing co-design with an advisory council that has been engaged kind of throughout the entire process to really point to recommendations. So back to that diagram, the pandemic has added this extra layer where before, some of the challenge was often, maybe there was inadequate support or is navigating or connecting supports. And then all of a sudden things were just eliminated during the pandemic. So school supports, developmental supports, respite for caregivers, community. And this is I think a very impactful quote from from a parent participant. And when schools shut down, all of the therapies all stopped right at home right away. That week, my son ended up becoming extremely violent. He was admitted to the mental health unit. For 5 months, he was in and out of hospital, only home for a few days in between every time. So, this, I think, quote is quite powerful and illustrates how important a lot of those supports are and how important the school system is in particular in sort of access to a lot of the mental health supports in the current system. So during the COVID-19 pandemic, there have been a number of different impacts for youth and families. Some of them are really just the barriers to accessing services. Things were shut down, families felt isolated and very much on their own. The mental health supports that were provided, and generally they were just the existing supports that anyone in the community would access, often just didn't have the resources to meet kind of the unique needs of a child with a developmental disability and the needs of the caregivers. So, this is, I think, one of the pieces I'll speak to in the recommendation section around the need to kind of have in some of these mental health strategies have tailored supports. And again, I'd highlight the really key role the school system plays in this and how the pandemic had really eliminated that. This resulted in increased mental health challenges for both youth and for caregivers. Deconstruction of social networks, isolation and loss of community, reluctance to enter public spaces, some of the physical barriers that exist to participate in community, and some of the developmental and academic progress that resulted was really impacted. And Dr. Williams had touched on this as well, the decreased capacity of caregivers, in the sense that often they were taking on now this role, extra roles in the home as educator or therapist and sort of virtual supports, and just the toll that takes in terms of trying to be able to keep up with their own needs and self-care. And the challenge there was also the lack of respite that was provided in the home. So, and then I just wanted to point to another quote from a mother of multiple children with neurodevelopmental disability who spoke to, things being shut down overnight and supports literally evaporating. Families like ours, you saw the difference immediately. We went from being reasonably okay to crisis. While we're in a much better place right now, it took a very long time to rebuild that. So one of the pieces that we've been able to do with in partnership with our advisory council is develop some digital stories. I won't share them here just due to time constraints, but I'll point you to the website where you can access them and view them. One is Jillian's story, who's talking about her lived experience during the pandemic, and another is Sarah's story, talking her experience as a caregiver of youth with developmental disabilities. And they're really powerful stories, and I'd really encourage you to take the time to look at them and really just thank them for their bravery in sharing those stories, trying to get the message out there. So to wrap up, just wanted to speak to some of the disability inclusive policy design aspects that could really be game changing in terms of improving mental health outcomes for both youth with neurodevelopmental disabilities and their families. The first piece is really disability inclusive mental health supports. This is critical, and it means that supports need to be affordable. They need to be accessible, whether they're in a virtual platform or in person. The providers need to be skilled and trained in terms of understanding how to work with youth with neurodevelopmental disabilities and their families. And the investments that are coming out around mental health have to include that in there. So some of the, Canada Health mental health transfer or stepped care or Wellness Together Canada, some of those investments, be great to see specific targeted funding towards disability inclusive supports. The other piece is around income and caregiving supports during the pandemic. As you've heard, and as everyone has experienced, education system supports, respite, therapeutic services were canceled or very disrupted. which had a huge impact. At the same time, a lot of the COVID income supports that were provided weren't available to families of youth with disabilities, just because of some of their pre-existing programs they're a part of. And the caregiving support during the pandemic also many families were not eligible for. So we need to rethink how we design some of those income supports. This has been a huge issue during the pandemic. And it's encouraging to see some progress around the Canada Disability Benefit very recently in the last couple of days. Another piece is access to internet. You heard about an awesome virtual intervention from Dr. Williams. I think that one of the key pieces is making sure that families who are remote and rural or low income have access to high-speed internet to be able to access some of these remote services that are really fantastic and can be hugely supportive. Another piece is ensuring that access to disability supports and services in schools and from community providers are deemed essential services. So we have to make sure that these are something that persists during emergency situations and not just sort of an add-on when it's convenient. And then the last piece is just recognizing that designing policy from an accessible policy lens is just better public policy. And it's also good for everyone. The disability community has been advocating for virtual health visits, for remote working capabilities, and for public health awareness about protecting the vulnerable from infection. And this is something that only came about during the pandemic, despite the community's been advocating for years. And if we'd been able to do this more proactively, I think we would have been in a much better place. So I think it's a lesson in terms of let's learn and let's design disability inclusive policies so that children can learn, play, work, and pursue their potential in the community. Thank you. I just wanted to acknowledge, I forgot this slide, I just wanted to acknowledge the amazing research team that has been working on this project and our advisory council and our funders.
Thank you, Dr. Zwicker, as well as Dr. Salami and Williams for your phenomenal presentations. We see our audience members have several questions that have come in, and I'm going to take a moment to get them sorted. But while I'm doing that, we'll ask a few more poll questions to help us continue to improve the SPARK program. You'll have to select an answer for all 5 questions before submitting your response. Type away if you have any additional questions as well. So while you're answering the questions, the first question that's come in is to Dr. Williams. To what do you attribute the change pre and post COVID in the chart that you gave, given that you've always been virtual? So it's not a switch to virtual per se. What would you attribute the change to?
That's an excellent question. Thank you for asking it. And the change is because the behavior concerns were that much higher during COVID. So they had farther to go down. And what was lovely to see is that they went down to rates that we saw similarly, but they were starting higher given the distress that children were in and the families were in at that time.
Oh, that makes perfect sense. Dr. Salami, what are the next steps in your research?
So there are a few next steps. We are just conducting interviews now. What we initially did, I didn't talk about this, we've integrated a really strong patient engagement focus. So we sent an email out to Black community organizations across Canada to interview research assistants that will be co-researchers on the project. Surprise, surprise, we got around 150 applications from Black youths that wanted to work on this project. We chose 6 of them, and they meet weekly to discuss, the immersion results. And we've also trained them in interviews. So they're the ones conducting the interview. As I said, they've conducted 28 interviews. We are still coding our data and doing preliminary analysis. And after that, we'll move to, hopefully by July, we'll start a survey of Black youths across Canada. We will be refining some pre-developed survey tools and integrating some of the findings from our qualitative interview. So, for example, some of the new findings is the influence of immigration status, which were not in previous survey tools, or the intersection of income and the anxiety that lack of income creates for youths. And then after that, we'll do a survey. And after the survey, we'll open that, maybe in the next project scheme grant, we will be engaging in a research project that would involve the development of an intervention to address mental health of Black youth post-COVID-19.
Great. So lots to look forward to. Dr. Williams, what are some of the perceived benefits of virtual mental health care for at-risk children and their families?
Another wonderful question. I think there's a lot. I think in the one slide I had that listed many of the barriers to traditional services where families have to take off time to work, or they have to, negotiate childcare. There's a lot of barriers that virtual can work around. And one of the things we found in our approach with this particularly parenting supportive program is the value of the families actually practicing and talking about these skills and concerns in their own homes. There's a level of comfort, and then you get to know the families the sort of the validity of the work we get to do is that much richer when there's not the transfer from my kind of boring office to their home. So it really, not only in terms of the barriers to actual access, I think there is a transfer effect that's a little bit stronger when you're actually delivering them in the home. But that being said, I think it's important to reflect, as Dr. Zwicker alluded, that there is barriers to even virtual care and safety issues in terms of having that trust in a therapeutic relationship that has that level of intimacy and bringing them into your home. So we've met with a lot of positive acceptability, but always sort of have our critical eye on who we maybe miss and how we can optimize the program for all families to help them for optimum comfort.
Definitely an important perspective. Dr. Zwicker, were there differences in perspectives between caregivers and youth? And if so, what were they?
Yeah, I think one of the biggest things we heard, so there were some similarities in terms of a lot of the mental health impacts, like both caregivers and youth were experiencing kind of additional challenges and feelings of isolation. I think one of the things that came out of the caregiver specific interviews were a more kind of cognizant about the challenges of accessing services and supports and kind of the system level perspective and just the thought that was going into that and kind of the additional roles they're having to take on. Whereas for youth, a lot of the perspective was around just really feeling isolated and challenges in terms of trying to interact and navigate in kind of the virtual environment. And in some cases, it was seen to be a positive, like there was kind of differing perspectives, and it depended on the individual as to how people enjoyed, say, virtual school or virtual therapy support. So I think this is the big lesson, is that some of these new delivery models can be really positive as long as they're accessible, and just recognizing it's not a one-size-fits-all approach. There has to be kind of adaptability and versatility to the needs of the individual child and family.
So added to the kit bag of options that we offer folks.
Absolutely.
Dr. Salami, what can we as healthcare professionals do to address anti-Black racism and the issues of equity that come along?
I think there is a lot that we can do to address issues of anti-Black racism and equity. The first step, of course, in addressing racism is being anti-racist. And one of the ways to do that is examining, one's value. Another way is being an ally, and being an ally is not just, you do one thing, on one day, you're like, oh no, yes, I'm an ally. But in being consistent with your efforts to address and challenge racist structures and processes. And the other thing is, learning and getting to know more about Black people. So, of course, the quote that I presented is a quote about anti-racism and being able to actually support the Black youth who is experiencing challenges related to issues of race and racism. And I think it's also often, I also often encourage policy health service providers that you should try to get to know someone that is different from you. Someone that is different from you on the grounds of race, on the grounds of gender, on the grounds of nationality is important. And also acknowledging that Black populations are not monolithic, and some of our youths have said that there's no Black community. There are Black communities. Engaging and thinking through about intersectionality in the work that we do. So, for example, some of the youths that I've discussed with in the past from LGBTQ2 background, they talk about, they go to the Black community, they experience racism. They go to the LGBTQ2 plus community, they experience, they go to the Black community, they experience homophobia. They go to the LGBTQ community, they experience racism. So where do they belong?
Right.
So addressing some of those.
Yeah, the intersectionalities are very important for us all. And our last question will be for Dr. Zwicker. What are steps that healthcare organizations that serve children and youth can do to be more disability inclusive, particularly in light of emergency responsiveness, but in general as well?
Yeah, that's a great question. I mean, I think one of the key points is recognizing that a lot of the supports provided to youth and their families should be deemed essential services. This has kind of, I think, been one of the big eye-opening aspects of the pandemic is how, and I was trying to frame it as that there was certainly challenges prior. Like, it's not to say this has not been an issue before in terms of access, but we kind of went from challenges in access and services that were meeting the individual needs of youth and families to having nothing available. And so I think the very first step is ensuring that a lot of these supports and therapies are deemed essential services and must continue during even emergency situations, because it's just not practical to be expecting that families and caregivers are going to be taking on all of those roles in addition to the roles that they're already fulfilling. And then I think the other key piece is ensuring that in terms of your delivery of supports and services and design, that you're doing consultation and have an advisory council and have youth and families informing some of that work, so that you're able to tailor supports and services either in a virtual or an in-person setting that think about some of the unique needs and diversity that is in the community, because it really can't be a one-size-fits-all approach.
Definitely. The importance of understanding your end user or your patients or the children and families that you serve seems to be key across all of your presentations as well. Well, that's the end of our time together today. Thanks to Dr. Salami, Williams, and Zwicker for sharing your time and expertise with us. Thank you to all of our members and other attendees for choosing to join us today. We know how busy you all are. Keep an eye on your favorite podcast platform, as the next episode of Spark Conversations will be released on Monday, May 30th. We will be hosting Dr. Chaya Kulkarni for our discussion on Missed Opportunities Can Last a Lifetime, the state of infant and early mental health in Canada. It's always great if you can watch live, as your questions and comments really enrich the discussion. But if you can't, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. So thanks again for joining us today. Thanks to Drs. Salami, Williams, and Zwicker for this presentation. And hopefully we'll see many of you back here soon. Bye for now.